Great. Good morning, everyone, and welcome. Do you guys see the screen?
Yes.
Thank you. Let me move that out of the way. All right, so let me, I'm gonna throw this in. I did send out the link to the agenda in the meeting invite this morning. And I'm gonna drop those links into the chat box just in case you didn't get them. I failed to, for Action Health Partners, when they come to their presentation, they had a one-page flyer. I failed to put that in the meeting invite, so that's also on one of those links that I just sent you. So why don't we, let's see if I can get my cursor back over there. Why don't we start with introductions? I just want to say, can you guys believe it's already December 2020? And it's our last meeting of December. It's crazy. I don't know if I should be like sad that this year's flown by or happy that and ready for 2020 to just be over with. I'm just afraid that 2021 may be more of the same. That's my fear, unfortunately. All right, let's start with introductions. I'm gonna see something real quick and pull it over to another screen. I'll just call out your organization, and if you'll just introduce yourself, and then we'll keep going. We'll start with Action Health Partners.
Deb Miller is here.
Caitlin Quirk, I'm here as well for presenting today.
And Paige Bartholomew, I'm also here.
Good morning. How about AmeriGroup? Do we have anyone from AmeriGroup? Beacon? Cascade Medical?
Hi, this is Christy Ann. And I'm Karen.
Good morning. Catholic Charities?
Hi, Sarah Van Horn from Catholic Charities.
Dusty Rocha from Catholic Charities.
Good morning. The Center for Drug and Alcohol?
Paul Hadley from the center.
And this is Loretta from the center.
Good morning. Children's Home Society of Washington.
Hi, this is Tori Gilden.
Good morning, Tori. Columbia Basin Family Medicine. Columbia Basin Health Association. Columbia Valley Community Health.
This is Mary Louise Jones from CVCH.
Good morning, Mary Louise. Anyone from the Colville Tribe? CHPW.
Good morning, Wendy and everyone. This is Connie Mumching with Community Health Plan of Washington. Thank you so much for letting me listening in sooner. Thanks.
You're welcome.
Morning, this is Kristen Stagner from CHPW as well.
Good morning. Did y'all hear my texting coming out when I say W? I realize that as soon as I say it instead of W, that's very difficult for me, just letting you know, little play TMI. Confluence Health.
Tessa Timmons here from Confluence, representing the behavioral health side.
And Stephen Johnson, also on from Confluence Health. I'm new to this group in a new role here at Confluence Health and joining from the primary care side of things.
Great. Welcome, Stephen. We look forward to working with you.
Thank you.
Coordinated Care. Cooley Medical Center.
Hi everyone, this is Shoshana Palmentier from Cooley Medical Center.
Good morning. Family Health Centers.
Hi, this is Melody, and I believe Ton is on as well.
I am. Hello everyone.
Good morning. Grant Integrated. Lake Mid Valley, and you take Lake Shan off my list. How about Mid Valley?
This is Diana Osborne with Mid Valley Clinic.
Anyone from Molina?
This is Vicki Evans. Good morning.
Good morning. About Moses Lake Community Health Center. Okanagan Behavioral Health.
Hi, everybody. This is Lisa Apple.
Good morning, Lisa. Samaritan.
Hi, this is Jan Sternberg.
Hey, good morning. This is Joe Ketterer, Executive Director of Clinics of Samaritan.
Morning, Joe. Anyone, how about CCMI and CSI?
Hey, Christina's here from CCMI.
Good morning, Kathy's here from CSI.
Roger Sharfgay is here as well.
Good morning. Okay, and how about from NCACH?
Mariah's here.
Good morning, Sahara Suval is here.
Good morning.
Good morning, Linda's here, and I don't know if you can see this, but I'm going through this 5-fluorouracil pre-treatment due to skin cancer issues, and my face is burning up, and I don't know if it shows how red it is, and it's going to be even worse next week, but it's so appropriate to do it during Christmas time, like a light bulb.
Good morning, Linda. All right, any other of our partners that joined as we were calling off organizations, but you weren't able to introduce yourself? Do you want to go ahead and unmute now and introduce yourself and say what organization you're from? We caught everyone on the first round. That's great. All right, so we're going to go ahead and move on to our consent agenda. I put the links, I will put them in there one more time just in case you joined in after I put them. They're in the chat box. So if you want to take a look at today's agenda and the minutes. Do you love it when your computer doesn't want to respond when you click on something? Okay, whenever you get a moment and you're ready to make a motion to approve both the minutes and the agenda. Today we have the pleasure of hearing from Action Health Partners and from Cascade Medical, two of our partners, as part of partner presentation. So I look forward to that. I just have a few announcements that we'll do prior to that, and then we'll do a quick roundtable at the end. So possibly, depending on discussion, may even get out a little bit early. So if someone would like to entertain a motion to approve both the agenda and the minutes.
So moved.
So second? Thanks, Joe.
I second.
And who was that?
Sorry, this is Ton. I'll second it.
Thanks, Ton. Sorry, you're with so many videos, you popped off my immediate screen, so I wasn't able to see you. So this is always the hardest part of getting everyone unmuted to approve minutes. So why don't we say if anyone is opposed, either chat in or unmute, and I'll wait a few minutes. If you don't want to, you can always private chat me if you'd rather that. But I will wait just a minute for that. All right, seeing none and hearing none, we'll say that the consent agenda is approved. On to announcements. So I'll start with partner updates. Any of our MCO partners have any updates that they would like to share today? I see Vicki shaking her head no, and I don't think I heard anything from AmeriGroup or Coordinated Care or CHPW. No, CHPW we do have on, excuse me. Kat or Kristen, not Kat, Kristen or Connie.
Hi, Wendy. This is Kristen. I don't have any updates.
Great. All right. How about from Action Health Partners? Any updates from you?
I don't think so, Wendy. Caitlin will take care of it during the presentation.
Great. Thanks, Deb. And how about our clinical partners, primary care and behavioral health? Anyone have any updates I would like to share with the group? Anything new, exciting going on that you would like to share?
This is Lisa with OBHC. Our new CEO starts December 14th. Will actually be up in our area and physically here. So we're super excited about that.
Great. Are you able to announce his name and tell us anything about him?
Oh, yes. Sorry. His name is David
It's okay.
McClay. He actually comes from the West Side where he was a CEO at another agency over there. And he and his wife have always wanted to retire in the Lake Chelan area. So being here in Okanagan County really works for them and their family. So we're excited to have him come on. We also have a new chief clinician. What is the title? Chief Clinical Officer, excuse me. Quinn, and I can't remember his last name. He'll be starting in January. So got a whole new team that we're queuing up and ready for 2021.
Great. That's exciting. I'm glad you're able to find in both of those positions someone so quick.
Yes, we are too. We're super excited.
Great. Any other announcements?
I'm not sure if this was announced already. This is Jamie from Catholic Charities. Our director, Carol Opal, has decided to leave our agency. She's been with us for a little over a year, so we'll be looking at filling that position.
Thanks, Jamie. We'll miss Carol. She was a good addition to your group.
Hi, Wendy.
All right. Yes.
This is Shoshana at Cooley Medical Center. Just to give everybody a quick update. Today is our go live with our new EMR system, Cerner. So I'm actually in the clinic right now, and I might have to get pulled here and there. So just want to give you a heads up. I may need to leave a little bit early, but that's some good news for us. We've been preparing for a little under a year now for today. So it's pretty exciting.
That's very exciting, Shoshana. It's been a long road for you guys, so that's very exciting. Thanks for joining us as much as you're able to today, but we do understand if you have to get pulled. Anyone else have any? I will say for all of those who've undergone EHR transitions, you know where Shoshana's at, so send her some love. She may need it. Okay. All right, let's keep moving then. Few announcements I have. We do have our population health plan for those who are participating tomorrow. I think all but one of our teams is, and so that's from 12 to 1. I will be uploading the presentation and the agenda to the portal after this call, so you can look for later this afternoon. You can look for that. Our December QI affinity group was canceled due to the holidays, and we understand the surge, and everyone's really busy. So we canceled December. We will resume in January. Also, we have canceled that January WPCC meeting, which would have been January 4th. Again, we understand everyone's busy. We will have the holidays, and just thought we would take a quick break through January on the WPCC meeting, and we will start 2021 off in February. So mark your calendars. I will be sending out meeting cancellations. Right now we're on this, the meeting invite it's like a non-stop every month recurring meeting. And I will cancel that because we have a lot of individuals on there who are no longer either with organizations or have transitioned roles and not in the WPCC. So you'll see new ones coming out. They will be individual meeting requests this time so that I can better control the who's on that invite, so that when someone's no longer wants the meeting invite or the information, it's easier to get them removed. I've removed people many times, but they still continue to be on these invites, so I'm struggling with that. So I'm just going to start from scratch. So beware of that. You'll get several of them back to back when I start rescheduling them. And then finally, we had talked about doing a design thinking workshop. You may recall Roger spoke about that a little bit. I'm going to have him talk about it a little bit more, and then I have a poll for you guys of when we should get this scheduled. So Roger, why don't I turn it over to you?
Sure, thank you, Wendy. We've mentioned this before, that in the work plan for this year was to introduce a design.
Roger, I'm sorry, it's really hard to hear you. I don't know if it's just me or.
Is this any better? Is this any better?
Not really.
Can you hear me any better now?
Yes,
much
thank
better.
you.
All right, I'll speak much louder. In the work plan for this year was to introduce a design thinking workshop. For those of you that are not familiar, this is a methodology that's very complementary to the model for improvement that we've been teaching, where we ask you to be clear on your aim, understand how you would measure success, and to identify what changes you want to test. Do that then through PDSA methodology. The design thinking workshop uses human factors engineering concepts and really focuses on helping you as a precursor step to identifying your aim, really understanding what the problems are, developing deep empathy for those that are articulating the problems or issues. And then it uses methodologies to quickly identify changes you can make and then rapidly prototype. So this helps accelerate some of the PDSA work that you might be testing. It's the aim of the workshop is really a train the trainer. So those who attend it would hopefully be able to leave, be able to run a design thinking initiative in their own organization. The workshop is limited to 25 participants and would be run over a 2 half-day consecutive days. So a Wednesday or Thursday mornings or afternoons as an example. And it was proposed to do this at the end of January, early February, or push it off to a future date, possibly as late as next summer, depending upon the bandwidth and interest of the group. So I'll stop there and see if there's any questions. Any questions?
Okay. I don't see any in the chat either. Excuse me. I'm going to launch a quick poll. We were trying to decide when's the best time to get this scheduled, and I felt like I wanted you guys to make that decision versus me, since you guys would be the ones signing up to attend. The options are mid to end January. I think it was actually end of January, that last week of January, mid-February, or do you guys just want to push this off until the summer? So I'm going to launch this poll, and if you're on the CCMI, CSI, or NCACH staff, I would ask that you not take this poll. Give it about 5 more seconds. I think we have about everyone. I'm going to end the polling. I'll share the results. Can you guys see the results? You didn't help. You kind of helped me, but you're split there. Mid-February or wait until summer. I think we'll take this information, and Roger and I will have a discussion, see what the best, if we have about 8 organizations or 8 individuals. I guess I don't know if that's organizations or just individuals. Maybe we may reach out a little bit to filter that out to better understand. It is only limited to 25 participants, so maybe that's, and we would like probably 2 at least 2 people from each organization so that the institutional knowledge is not just within one organization or within one person within that organization, and also that you can work together as you plan your own design thinking within your organizations. Roger, do you have anything else?
No, maybe
like
we'll
that?
put together a little flyer just explaining it in depth and send it out and then see if there's any recruitment for February.
Perfect. All right, so let me stop sharing that. Wanted to say thanks everyone for signing up for the WPCC presentations. I think I have 2 organizations left, one MCO and one clinical provider that we're waiting to sign up. The schedule is pretty much full. I think there's 1 slot in June and 1 slot in August, so we'll have 2 presentations each month. Just to clarify for those of you who signed up, I will be in touch with you a month prior to when you're presenting and let you know that we'll just get your slides in that week prior to your presentation, so you'll remember. I do ask that for the clinical partners that you do present on some WPCC type project that you're working on, whether it was something that you implemented prior to us narrowing it down to more depression and diabetes, that maybe it was some of the work you did with social determinants of health or access this past year or in 2019, and you're continuing with that project, or if it's the new diabetes and depression work that you're working on, or SUD, mental illness, that we're currently working on, that you do limit your presentations to that. I do know we have a few that are on COVID that I have agreed to because they're right at the beginning, and it's some new work that it's not the same old stuff, but it's a little bit different spin on some of the stuff that we've been talking about. So you'll have one today and then one in February on that. Improvement charters, we have most of them in. I think we have 11 of the 15. Those last 4 we've been in discussions with. We're waiting to get those in. We're reviewing those. You will see that I have questions. They're not being scored like they were last time, but I am asking questions for clarification and making sure that we definitely have a plan as we move forward in 2021. I know some individuals, because that's when the surge started happening, kind of just threw something together really quick to meet the deadline. And so they're currently improving that and making sure that it's meeting with their teams and making it a little more robust, and I appreciate that. Next is monthly reporter, just a monthly report. Just a reminder that it's due the first Wednesday of the month, so the next one will be due January 6th. That is the narrative and the metrics reporting. The only thing I ask on that one is in the portal, both the narrative and the metric report has been uploaded. I ask that you either use that's uploaded to update, or when you put another one in there, that you delete your old one, so we don't have this massive run of documents, but that we only have 2 documents per organization, and it's the most updated document in there. Please check your metric report in the portal for the template. Mariah and I are updating it to make sure that you have the correct reporting period for the correct column. There's been a little bit of confusion on it. I've been confused. And so we are updating that to hopefully clarify that for it. So if you do the reporting, just take a look at that, those top rows. We're not messing with the data, just clarifying the columns themselves. And finally, we did receive our pay for performance results from Healthcare Authority, the 2019 results. Those will be compared to 2017. I asked Caroline to dig into that a little bit and come back in February and present that to us. If I remember correctly, when she did a quick scan right after we got it, I think we met or exceeded 13 of, I believe, 25 of the submetrics. So if you want a little bit more about that, Caroline will be presenting on that come February. Any questions on anything on this slide? Reporting, improvement charter, presentations. I should say on the WPCC presentations, I didn't mention for the MCOs, you guys have some programs that are very relevant to our clinical partners. So if you would like to just present on one of those programs, that would be great. If you guys, some of you may remember, I'm sorry, I don't remember if it was Ameri, I think it was AmeriGroup presented on their expert work that they do with the clinical organizations. That would be a good example. November, there was a value-based care summit put on a joint by Bree Collaborative and the Washington Health Alliance. It was a really good summit. There were 2 keynote speakers that I thought were really good, very interesting, and very relevant to the work we're doing. I put the YouTube link on there so you can watch the video. If you go to the Bree Collaborative, Google Bree Collaborative Value-Based Care Summit, that should come up as well. But there's a YouTube link if you're interested in listening. The entire, it was a half day or 3 hours, 3.5 hours. It's all on one YouTube link, so you can just scroll through. I think it was the first and third presentation that I thought were the most valuable, but feel free to listen to any component of it. Very interesting. The last thing I wanted to mention is the Healthcare Assistance Authority submitted to CMS for a 1-year extension and amendment. This would give us a 6th year in the MTP because we've been delayed due to COVID. It has to be approved by CMS as well as the Washington State Legislature. I'm putting this here because they have opened it up for public comment and they've extended that through the 13th, December 13th. So that's next Sunday. If you would like to make a comment regarding their extension or the amendment that they've submitted for, there is the link there. You have these slides. You can also get it from there at a later time. Anything else on any of the announcements? Either unmute yourself or feel free to chat. Say again?
I'll share that this morning the ACH executive directors had their monthly call with the Healthcare Authority, and there have been 30, I can't remember it's exactly 33 or 34 positive comments in support of the 6-year extension, and 1 person who asked a question and they didn't share what that was. So anyway, it's been positive so far. And Alicia Fehrenbacher from Pierce County, and that's called Elevate Health, and Allison Polson from Better Health Together and I are the 3 ACH executive directors asked to be the messengers to the legislature on the 6-year extension. And what we're waiting for is to see if the governor puts that recommendation in his budget, and that budget should come out around December 15th.
Thank you, Linda.
Yeah.
Any questions, comments? Okay. I'm going to turn it over to Cascade Medical.
There you are. Hi, everyone. I'm Karen. I am an LPN here at Cascade Medical. COVID has definitely taken a big part of 2020. So I just wanted to put a little presentation in regards to what we're doing here at Cascade. You can go ahead and click the next slide. COVID-19, it's definitely a new coronavirus that has not been previously identified. I didn't put too much information simply because we have been dealing with this for quite some time. It is a severe acute respiratory virus apart with the COVID-19. Go ahead and click the next slide. All right, so here are a few of the symptoms that are recognized by the CDC: fever, cough, shortness of breath, chills, fatigue, muscle pain, headache, sore throat, loss of taste or smell, or both, diarrhea, nausea, vomiting, congestion and runny nose. Emergency warning signs would be trouble breathing, any bluish lips, inability to wake or stay awake, confusion, persistent pain on the chest or pressure in the chest. And these are symptoms that we would definitely triage by one of our RNs to see if the patient needs to be seen in respiratory clinic or an emergency department. And I will go over a little bit over respiratory clinic and how that was created. So these are the main symptoms that we kind of look for when patients are calling. stating that they would like to get tested for COVID, or what they do if they're feeling these certain symptoms. The key symptoms are fever, tiredness, cough, loss of taste or smell, breathing difficulties. Although those are the key symptoms, we have seen majority of the ones listed that are recognized by the CDC that you'll see towards your left. Next slide. So employee screening, every day you're scheduled to work, we do employee screening to make sure that we are healthy and ready to work. At the entry, in each entry station or each door that we have entering the building, we have screening stations where we have a surgical mask that we can wear. We take our temperatures, hand sanitizer and sanitation cloths to clean after you screen. We are required to wear masks and switch them halfway throughout our shift if soiled. We are also required to take our temperature prior to entering our building or workstation, and we do submit a health screening as soon as we get to our workstation with a series of questions in regards to if we're feeling ill, if we have been hanging out with anyone else at our household, and I'll go over a little bit more detail on that. Once we complete the questionnaire, it'll automatically let us know if we have to see our employee health nurse, which is Samantha Jerome, or if we are cleared, we'll immediately get notified. And again, if we are feeling ill prior to work, we are to call and just let them know what's going on, what we're feeling. One of the main things is if we wake up feeling ill, we're not to come to work, just to be safe and keep others safe as well. We do contact Samantha Jerome, who is our employee health nurse, as well as our director. Next slide. So these are examples of the questions that we answer. Just going over for if we have any of these symptoms within the last 72 hours, if we have had any known exposures, if we were exposed to anyone, if anyone in our household has been tested for COVID, if we've been taking any medication, current temperatures. These are extremely important because we deal with patients on a daily basis. We don't want to be, getting others sick as well as employees. We are very important to keep everybody healthy. So we do ask for everyone to answer these as honest as they can. And if they have any questions or any concerns, they contact Samantha, which is our employee health nurse. Next slide. We also do patient screening at the door where patients are asked if, prior to their appointment to wear a mask, but we do provide our surgical mask at the door for them so they can switch that over. We take their temperature, ask them if they have any symptoms during that day, if they have had a possible exposure, and if they do have any symptoms or they have had an exposure, we definitely ask for them not to come in and that we would contact them in regards to scheduling an appointment. If they're not feeling well, we do triage them with our triage nurse. Just again, evaluate to see if they need to be seen in respiratory clinic or if it's something severely that they need to be seen in the emergency department. We do this again to keep not only our staff safe, but other patients safe as well as the patient. We want to make sure that the patient has been taken care of. And we do offer telehealth and telephone appointments as well for those that qualify under, not having to necessarily be seen in clinic, or if they prefer that option, if they want to go ahead and speak to a provider, we do have the option for them where we guide them what link to choose and how to go about that. So again, those are a few of the examples of the symptoms that we do ask our patients when they walk into the door. Next slide. All right, so here is our respiratory clinic. It's a clinic that was specifically designed because of COVID. So respiratory clinic was created in a separate area in our hospital. We have 2 rooms where we treat patients suspected of COVID or have symptoms related to COVID. This clinic was designed to keep the patient, other patients, and staff safe. Make sure there's no contamination, nobody's contracting the virus. So these patients are usually scheduled in a respiratory provider for that day, and it changes on a daily basis which provider will be scheduled for that day. And it goes from 1 to 5 o'clock, usually calls are received from the receptionist, support staff, the triage nurse, or myself to evaluate the symptoms and determine if the patient needs to be seen in a respiratory clinic. So the patients are instructed once they arrive to park by the emergency department. We have parking spaces that have respiratory clinic labeled on there, as well as a phone number where to call to notify that they have arrived. They are instructed to remain in the vehicle until the nurse, the support staff is available to walk them to the respiratory clinic. Once the support staff is ready, they'll notify the patient. The patient will walk to the emergency department door. Right there, the support staff will provide the patient with the mask and let them know that they will be going to respiratory clinic and guide them to that clinic, making sure that there is no contamination. Once they arrive into that respiratory clinic, it's, again, it's a separate room. We have our laptop in there. We don't have paperwork that goes in there. We try to keep things very separate so we keep them clean. The patient will be evaluated right there. The support staff will ask patient questions, how they're feeling, if they had a possible exposure. They will have a COVID test as well. And we do a rapid in-house COVID test. The patient will be notified of the results right there and then. That way, it also alerts the provider what to expect or how to approach these symptoms. And prior to respiratory clinic, we do wear PPE. It's very important we don the PPE. The support staff dons the PPE prior to even going and getting the patient in the emergency department, making sure that they protect themselves. And we keep that in a separate area as well. That way there's no contamination, which is right outside the respiratory clinic. And as well as the providers, they don PPE. And again, they're evaluated. The provider will go ahead and see what they can do for the patient. And if it's a severe case, then this provider will see if the patient needs to be sent to the emergency department. Next slide. So our new role that we have kind of we have established has been COVID coordinator, which is me. Because COVID has become such a big factor in our lives in 2020, having a COVID coordinator has been very helpful on our clinic floor. We have a lot of questions that come in regards to COVID, how to get tested, when to get tested, what symptoms to look out for. One of the biggest questions lately has been the vaccine. So I work with Samantha and Alex. Samantha is our employee health nurse, and Alex Riggs is a RN who works with infectious disease here at Cascade, as well as I work with everyone here on the floor in regards to questions in their patients. One of my duties is I keep track of outpatient testing numbers through a spreadsheet to make sure that we have an updated number of how many people we've tested, how many are positives, negatives, how many of our tests have been rapid in-house, and so forth. And I send that spreadsheet to Samantha, who keeps track of that and sends it off to our board members. I also help in scheduling outpatient patients for testing, and I explain what's going to happen, when to arrive, the time. We usually have them arrive and park by the emergency department, where I test them while they remain in their vehicle. I collect nasal samples from the patients and I transfer those to the lab. I call the patients with results, whether they're negative or positive, and I provide education on both results. For positive cases, I do contact tracing, where there's a series of questions that I ask that I do have an example on another slide that I'll go over. I also answer any questions that patients might have in regards to COVID in general. And it's just, you know, I'm here, this role was created to help and kind of alleviate a little bit of questions that other support staff might be getting. That way they have a main source to talk to and see if those questions could be answered. Next slide. You can just keep on clicking because there's like a whole bunch of little ones. So this is just an example of my workflow. So every morning I arrive, I collect my COVID report of the patients that were tested the previous day to update the spreadsheet. I always confirm our numbers with lab to make sure that we have matching number of patients were tested, how many were rapid, how many were sent out to Quest, how many were positive, how many were negative. That we make sure we're on the same page and we have those correct numbers. I go ahead and review the results and I call patients, whether they're negative or positive. Usually those who are positive, I call first to make sure that they have been in quarantine and isolating, and as well as doing contact tracing. And again, I'll go into detail with that. PSRs, which are receptionists, the triage nurse, and myself, we schedule accordingly on our outpatient schedule. If we have any of those patients who symptoms might be a little questionable or we feel like they need to be triaged, then we definitely send to the triage nurse. It'll be evaluated. The patient needs to be seen in a respiratory clinic, or if the patient cannot wait to be seen in a respiratory clinic, we do recommend the emergency department. And we always notify, if that's the case, we do notify the emergency department if there's a patient with possible COVID coming in. That way they prepare for that as well. Outpatient testing takes place from 1 to 2:30 Monday through Friday. Once patients arrive, they are checked in remotely. They let us know that they are here. I'm usually already out there, and I always tell patients that they'll see me in PPE by a tent. So they'll just flag me down and I go to their vehicle and I test them in their vehicle. Once I am done testing, I go ahead and gather all the nasal swabs that are in the biohazard bags and I transfer them to the lab. And then once the lab processes, I call the patients and provide instructions whether they are negative or positive. You can yeah, I think there's a few more. Again, with positive results, I do contact tracing. During clinic hours, the triage nurse cannot determine whether the patient needs to be seen in respiratory or can just simply do an outpatient COVID test. Right now, due to our high demand in testing, we do send out some of the tests to Quest, and it takes about 48 to 72 hours for us to receive results, which we do let patients know in the meantime to quarantine. And then if their symptoms progress or they get any worse, we do also recommend that they give us a call so we can evaluate and see if they need to be seen in a respiratory clinic. Go ahead and next slide. So this is the testing criteria at Cascade Medical, where we determine, you know, if we need to do a rapid on the patient, can it be a Quest send out? So testing for symptomatic and exposed individuals include employee health, first responders, Cascade School District, Mount Meadows, respiratory clinic, emergency department, acute care, and endoscopy. We tend to do rapids for these employees, or the employees, sorry, for the listed below. And rapid means we get the same day results. And we call those patients, notifying them in regards to the results. And the reason these qualify, again, employee health, we want to make sure employees are healthy and we continue to keep our hospital healthy and again, free from contamination. Mount Meadows, emergency department, we all deal with patients and we try to keep these, again, we try to keep everyone safe and we want to know the results as soon as we possibly can. Outpatient testing, including symptomatic and asymptomatic patients, due to our high demand, we are sending these to Quest and it's taking about 48 to 72 hours. We're currently not testing for travel or gatherings because, again, to kind of we want to bring down our percentages for COVID. We don't want to raise them, so we advise against traveling and gatherings since we should not be doing that. Again, also for our governor. That we use a foam tip, anterior nares collection, and then we put those into viral transport media and we send those with Quest. When patients call and they let us know that they have had an exposure, we do recommend testing 5 to 7 days after the initial exposure to detect a viral load. In the meantime, if patients are not within the 5 to 7 days, we do recommend that they quarantine and schedule them in that period so we can test them and detect something. When the testing information, we want to make sure that the patients are always, they always have a mask. We do instruct them to wear a mask. And the only time that they bring down their mask is when I'm about to do the swab, the nasal swab. They'll go ahead and pull down their mask below their nose. Usually explain exactly what I'm going to do. That way they know what to expect. I do a quick rotation swab in both nostrils for about, let's say, 10 seconds. And then I go ahead and put it in the biohazard bag, explain to them how long it will take possibly, and I would give them a call as soon as those results come in. And then myself, I'm always wearing PPE and I'm always changing gloves in between patients and hand sanitizing to make sure that there's no contamination going on. Next slide. Contact tracing. So for all our positive cases, we do contact tracing and there's a form that we fill out. when we speak with the patient, usually I like to, when I'm calling patients, providing education in regards to a positive case, I do contact tracing in that same phone call to answer a few of these questions. So the staff designated as an interview will contact the patient who has tested positive within 24 hours of return results. And then the interviewer will provide the following to the patient using the positive result data. So we want to verify the symptoms, educate the patient in regards to what to do, need to isolate, which for positive cases, we would want them to isolate. We let them know that the providers are here. If they have any further questions, or if they want to be seen, or if their symptoms are progressing, they can definitely be seen by a provider. Next slide. So here's an example of the sheet that I fill out when I'm calling patients. I always want to verify that I'm speaking to the correct person, so I verify their name, their date of birth, their address, and phone number to make sure, again, it's the same person that I'm talking to. I notify them of their results. I educate them. For example, for a positive case, we do recommend that they isolate for 10 days from the onset of when their first symptoms first appeared. And once those 10 days have been completed, they have to be symptom-free for 24 hours without using medication that will help reduce those symptoms. If the patient is still having symptoms and yet they've completed this 10 days, again, we do recommend that they continue to quarantine and isolate. If they live within the same household, we do educate to see if they can isolate away from the family members in the same household, stay in a room. That way they don't give the virus to anyone else. If that is not possible, for example, with little ones, it's very hard to isolate away from your little ones. We do assume that at one point the family will all get COVID, and we educate right there and then what symptoms to look out for. We do encourage to get tested as well as isolating, and we also ask if they need any help isolating, or if they need any help with food. And if that's the case, we do send it off to Aisha, which is our social worker, which I provide information as well. And again, if the patient has any questions, I go ahead and answer those questions to my best knowledge. If it's something that I cannot answer, I go ahead and send it over to a provider. But just looking at the page is just updating their address, looking over to see what symptoms they're currently experiencing or have been experiencing. The very important question is where they may have possibly contracted COVID, if they have been tested before. One of the big portions as well is their occupation, simply because we want to make sure that they notify their employer and notify to see if any of their coworkers need to get tested, and encourage for that testing, not only for coworkers, for family or friends that they have possibly seen during that period. And when I am done completing this, I send it over to, it's Alex. I think I provided the information as Alex, which is our, it's our health, I believe it's our health district where we go ahead and send these off to. Next slide. So these are a few of frequently asked questions. For example, one, I was recently exposed to a positive case. What do I do now? We do ask exactly when they were exposed and try to advise them to get tested within the 5 to 7 day period after the exposure for us to be able to detect a viral load. We let them know as well if we ask them if they have spent a total of 15 minutes over the course of 24 hours. Or if they've had multiple exposures with wearing a mask or not wearing a mask less than 6 feet apart. If they qualify for those are considered high-risk exposures, and we do recommend that they get tested. And then again, we do, on patient indication, we do advise to quarantine for 14 days from last exposure, regardless of the test result. Another question would be, I have a cough, should I get tested? Again, we ask if they have possibly been exposed, if they're feeling any other symptoms. Sometimes we do get patients where they don't know if they have been exposed to unknown exposure. So right there, and then I ask if they have been out, and then they'll say, I went to the grocery store or so forth. And depending on the symptoms, we do recommend that they get tested. And then one of the main questions that we do get is, what do I do while I'm waiting for my results? Again, we encourage strongly to remain in quarantine, to practice social distancing, wear a mask, wash hands, just so that way, you know, we don't want them to be out and about and possibly expose other people. And then again, if they're having symptoms, immediately isolate. And then how will I know what my results are? We always give a call. As soon as those results come in, we call those patients and we educate. Majority of the time it's me calling the patients. I try to get to them as soon as I possibly can. Again, with those positive results, I put those first and I call those patients first. Next slide. All right, so this is just kind of a conclusion. This pandemic has changed, you know, our lives in many ways. It's affected us not only as a state, but worldwide. Cascade Medical is taking every precaution to keep our patients and our community safe, trying to follow every CDC guideline, and again, working as a community to see how we can help our patients and keeping our staff safe. By adding respiratory clinic and a COVID coordinator, it's helped alleviate you know, all the current situation that's been ongoing during this pandemic. We do understand that the current situation could cause stress or anxiety. So along with patient education, we also offer help through Aisha, which is our clinical social worker, and Maxwell Maholi, who is our behavioral health consultant. And Cascade Medical is working closely with Chelan Douglas Health District and of course our Department of Health to treat the 2019 novel coronavirus. So we train our staff, we try to keep our staff as updated as we can as soon as anything changes and with any protocol to make sure that everyone is aware of how to handle COVID questions, or if a patient is calling and I'm not available or the triage is not available, how to handle that. Next slide, I think that might be it. Yep, that's it. And that's all. Any questions?
Thanks, Karen. If you have a question, feel free to unmute yourself or chat it in the chat and we'll read it all.
This is a great presentation, Mary Louise from Columbia Valley. Do you have a lot of folks when you're doing the contact tracing ask really specific questions about their issues? And do you guys have a system for then having a provider talk with them?
Yeah, so if, you know, I go over and I explain exactly what's going to happen. If they have any questions where I cannot answer or myself, I feel like I'm not answering them, we do send them to the provider. And it's usually the provider who is assigned for respiratory clinic that day that I will go ahead and forward this to, and that provider will go ahead and contact the patient.
Okay, great, very helpful.
Anyone else? Great. Thanks, Karen. We appreciate you going through this. And very interesting that you have a separate respiratory clinic and you've hired a coordinator to coordinate that, because we know that right now it's shouldered by a lot of people within organizations.
Yes.
All right. So the next presentation, I thought I would hold off on the small group discussion until see if we have time. So the next presentation today is from Action Health Partners, Caitlin Quirk and Paige Bartholomew. And Caitlin, did you say you wanted to run the slides?
That would be great if you could give me remote control.
Yeah. I'm working on it. Except I can't find my controls. Why don't you get started, and if I can get to it, I will let you know in the interest of time.
Okay, I just requested it, so maybe that will help. But I'll let
you
Paige.
Got it.
Perfect. I'll let Paige introduce herself.
Hello, everyone. Thank you for having us. My name is Paige Bartholomew.
Right, and my name is Caitlin Quirk, and I'm the Health Education Network Coordinator at Action Health Partners. Today, we're just going to be presenting on chronic disease self-management education and Action Health Partners' 7-year history of coordinating the chronic disease self-management education workshops. It's not letting me go forward. There we go. Okay. So today we'll be sharing what is chronic disease self-management education, or CDSME, Action Health Partners CDSME program information, some workshop data, participant demographics, and then some opportunities. But before we dive in to everything, I did want to just say that we're presenting on this program because we believe it's a really great program and has been supported at the federal, state, and local levels. We know it's not the only chronic disease or diabetes education resource, and it may not work for everyone. But this program has a lot of great evidential support, and we believe it's proven to be beneficial for our participants and community. And we believe that this program is a great addition to provider education and a critical peer component. Sorry, nothing's getting in the way. Okay. So chronic disease self-management education is a collection of Stanford evidence-based programs. So chronic disease, chronic pain, diabetes are just a few of those. The programs are now their own entity under Self-Management Resource Center, and they provide the fidelity, the licenses, and any program updates to those licensees. Kate Lord created the program and continues to run SMRC to this day. The goals of the various programs are to improve health status, quality of life, improve self-management skills, and self-efficacy through peer support and facilitation. And the target population are those with chronic conditions and their caregivers, either professional caregivers or family members. The 6-week workshops are facilitated by 2 trained and certified lay leaders. Lay leaders are peers with personal experience either with a chronic condition themselves or experience as a caregiver and family member. Small groups meet once a week for 2.5 hours at an accessible community location. Each week, lay leaders go through various sections teaching self-management skills such as medication management, emotion management, healthy eating, stress management, safe exercise, and they do this through brainstorming, action planning, and problem solving. Lay leaders are required and expected to stick to the strict fidelity of the program while inserting personal stories and experiences when it's applicable and guided to do so. We strive to make these workshops as low barrier as possible, with all locations being ADA accessible, holding it at various times of the day, and all materials are provided and completely free for participants. We did want to just acknowledge that there are 3 license holders within the NCACH region. AHP facilitates a chronic disease self-management education network meeting to work towards being coordinated in our efforts and hopefully one day being a little more regionalized on that. Family health centers, they provide workshops generally at their clinics, and as far as I'm aware, they have chronic pain, diabetes, and then a Spanish diabetes class. Moses Lake Community Health Center also is licensed to provide chronic disease and the Spanish chronic disease, and they do so to their patients in their 3 locations. And then we are licensed to provide 3 workshops in both English and Spanish, and now have lay leaders in all 4 counties and working to increase the capacity through partnerships throughout the region. So from 2013 to 2019, we've held 61 workshops in English and Spanish, 12 of those being chronic disease, 15 chronic pain, and 34 diabetes. Out of the 61, about 20 of those workshops have been held in Spanish, and a total of about approximately 504 participants have participated in one of the 3 workshops offered. This program has been coordinated by multiple people through the 7-year history, and some of the earlier years either didn't collect or report the workshop data in great detail or did not pass the data to their successor. So there could have been more workshops in the early years of this, but we just don't have the evidence to support that. But everything we're sharing today, we do have the evidence to support that. So the locations of chronic disease self-management that we've held so far, 70% of those have been in Chelan and Douglas. about 28–30% have been in Okanagan County. And this is just really dependent on where our volunteers are, because all of our facilitators are volunteers. We have the most available and the most, Chelan Douglas has the most of our volunteers. So that's where the majority of our classes have been so far. And we did just train 4 new facilitators in Grant County. So we have not yet held anything in Grant County. We have a 77% graduation rate, and in order to graduate, participants need to attend at least 4 of the 6 sessions. Again, due to the multiple coordinators of the program, we only have graduation rates from 2016 to 2019. But we think this retention rate really indicates the benefit of the workshops, and most of the reasons of why people don't graduate are due to illness, any family issues, or pre-scheduled travel or vacationing. The average number of workshops offered per year is 8, but in the past 5 years, our average number of workshops held per year has been 10. Action Health Partner currently has 20 active lay leaders. 25% of those were first participants who then got trained in the program themselves and then became lay leaders. We have all of our volunteers have lived experience with chronic conditions or as a caregiver. And we currently have 3 master trainers affiliated with Action Health Partners. Sorry, this keeps. My screen keeps popping up, the chat box pops up, and then I can't see the skip button. But we did want to note that Action Health Partners is contracted with DSHS to provide caregiver CEUs, and we provide these for free to our community. So if you attend all 6 sessions, that's 12 CEUs. And we just thought it was important to note and kind of interesting that in the past, from 2017 to 2019, we provided 35 people with CEUs, so that's around 420 CEU hours, and that's an estimated value from $8,000 to $35,000 that we've provided our professional community in the CEUs. And now I'm going to hand it over to Paige to go over some workshop data.
Thank you, Caitlin. Again, now we're going to review some workshop outcomes data when we compared the pre and post workshop surveys. I do want to note that, again, like Caitlin said, we offer 3 programs, and those programs do use different pre and post surveys. So for the chronic pain and chronic disease self-management programs, they use the RAND 36-item health survey to measure the quality of life. The survey was created by the RAND Corporation and asks about 8 health concepts ranging from physical functioning to bodily pain, general health perceptions, just to name a few. A higher score defines a more favorable health state. When we compare the pre and post RAND survey scores, 71% of participants increased their score, 26% decreased their score, and 2% stayed the same. In just 6 weeks, over 70% of participants saw improvements in their day-to-day quality of life. This is especially interesting when it comes to chronic pain, because chronic pain is variable from day to day. And then when we look specifically at the chronic pain self-management participants, it's 72% of them increased their scores. This goes to show the impact of self-management tools learned has on participants' quality of life. The diabetes self-management program uses a 14-question survey asking about diabetes knowledge, stress management knowledge, self-management confidence, self-management behavior, and feeling overwhelmed. The survey comes from Collis Health, now known as Comagine Health. When we compare the pre and post test answers, there was a 17% increase in diabetes knowledge, a 42% increase in stress management knowledge, a 10% increase in confidence around self-management, and a 42% increase in self-management behaviors. And then there was a 17% decrease in feeling overwhelmed. So specifically with the diabetes self-management program participants, when we take a closer look at behavior, 42% of participants changed their self-management behaviors. Increases or changes in behavior includes doing one or more of the following activities more often: eating 3 or more servings of vegetables low in carbohydrates, exercising at least 30 minutes, taking one's diabetes medication, testing one's blood sugar, and or checking one's feet. When asked the question, I will continue to use the self-management skills I learned in this workshop, 98% of participants either agreed or strongly agreed. When we compare the two, it's confirming to know that the participants who already identified making a behavior change within the 6 weeks of the workshop will continue to use the skills learned, as well as the other participants. When we take a closer look at confidence, 10% of participants increased their confidence or felt more confident in asking for support to live with and take care of their diabetes, asking their nurse or doctor about their treatment plan, and or making a plan to help control their diabetes. It should be noted that from the 3 questions that measured confidence, 85% of participants' confidence scores stayed the same. And of those participants who scored stayed the same, 96% of them already felt confident in asking for support, asking questions to their healthcare provider, and or making a plan. But what's more telling is that 85% of participants selected a confidence score of 8 or more when asked to identify how confident they were in managing their chronic conditions after taking the workshop. The highest response at 45% was totally confident. This goes to show the benefit of learning and building self-management skills and peer-to-peer sharing and learning. So now we're going to take a look at some CDMSE participant demographics. When we look at gender, 78% of participants are female, while 22% are male. When we look at age, a majority of participants at 45% fall between the ages of 60 to 79. It makes sense that this age category is so high because 60 plus was the target population when we had the National Council on Aging grant with Aging in Adult Care. We see that the percentages do increase between the age categories because as the older one gets, the more likely they are to have a chronic condition. When we look at race and ethnicity, 80% of participants identify as white, and 27% of participants identify as Hispanic or Latino. In North Central Washington, approximately 32% of the population is Hispanic or Latino. And as Caitlin mentioned earlier, since all of the workshops to date have been held in Chelan, Douglas, and Okanagan counties, approximately 27% of the population in those 3 counties combined is Hispanic or Latino, which aligns with the ethnicity data on the slide here. When we look at education levels, it varies. The highest response at 38% is some college or technical school. The main takeaways from this slide are 1, this program is applicable to all education levels, and 2, chronic disease affects everyone. When we take a look at health insurance, 43% of participants have private insurance, 36% have Medicare, 21% have Medicaid, 10% have Medicare Advantage, and 5% either don't have insurance or don't know. The workshop intake asks participants which health conditions do you have. There are a total of 19 options ranging from arthritis to cancer to stroke, as well as another category. 14% of participants identify not having a health condition. 86% have at least one, 71% have 2, 52% for more information. But when we're looking at these numbers, we have to consider how many of those participants are caregivers. Is 38% of participants identify as caring for a friend or family member, which means that even caregivers may have a health condition. This graph breaks down the top 10 health conditions of participants. The most common is depression or anxiety disorders, followed by chronic pain, hypertension, high cholesterol, arthritis, rheumatic disease, diabetes, and other chronic conditions. Then we have obesity, asthma, or other chronic breathing or lung problems, and then osteoporosis. And then lastly, the Diabetes Self-Management Program asks the question, have you ever taken a course or class in how to manage your diabetes? 80% of participants said no. When we specifically looked at the participants who identified having prediabetes, type 1 or type 2 diabetes, 81% had never taken a course or class in managing their diabetes. This leads us to believe that we are the first door people enter when they want to learn about how to manage their diabetes. Now I'm going to turn it over to Caitlin to talk about some opportunities.
Yeah, thank you, Paige, for going through all of that with us. So some opportunities that we are trying to implement or are implementing are virtual workshops. In response to COVID, we've shifted to virtual workshops because we obviously cannot hold groups of people with multiple chronic conditions together right now. And so we hope to see some improvements in geographical reach with these being virtual. There's actually someone scheduled, registered for our class in January who lives in Spokane. So we're already seeing that with our first class. We're hoping that it'll improve availability because we can use lay leaders who don't live in the same area. For example, our one in January, one of the lay leaders lives in Tonasket and the other one lives in East Wenatchee. But we are looking at ways to improve equity by looking at internal computer checkout programs for volunteers or participants, just because obviously moving to a virtual space for these classes limits the equity of the workshop. We also see an opportunity to really grow our lay leader and community health worker workforce with the program and to equip them with the appropriate tools to be successful themselves, but also to help their clientele be successful. The goal is really to teach participants and then for those participants to then become lay leaders. For an example, one of our chronic pain facilitators, she quoted, attending the self-management chronic pain workshop 5 years ago put my life on the right trajectory, and I began really using so many helpful tools from this course. My husband, Steve, suggested I become a lay leader. So just a success story of a participant becoming one of our most active volunteers. I did want to go through some partnerships that we have or are hoping to have. We, like I mentioned before, Family Health Centers has a license and they used to work under ours. So we still try to work pretty collaboratively with them to share volunteers and utilize them as best as possible. Some partnerships that we've had with Catholic Charities, we did a pilot project with them where 25 of their case managers went through a diabetes self-management workshop. The pilot provided case managers and the community health workers with self-management tools and from the workshop to share with their clients, but also knowledge of how impactful the workshop is and a better understanding of how to promote these workshops to their clients. We also are partnering with Confluence Stroke Program, Jamie and Terry with the discharge, post-discharge program where they follow post-stroke patients for up to a year. We are partnering with them mainly with our blood pressure monitor checkout program, but the hope is that as clients start to gain health and practice self-monitoring and self-management tools, that they'll be referred into chronic disease self-management classes to improve those self-management behaviors and lead to increased health outcomes in the future. We also partner with CoMagine, which was used to be Qualis Health, and their CDSME Hub Work Group, which is state partners and other license holders kind of looking at the future of how to best support CDSME within our state and our regions. And we're also partnering with some folks from Columbia Basin Hospital and Samaritan Hospital. We just trained 4 new facilitators. I'd say just trained, but that was in February before all of this COVID stuff happened. So we do have lay leaders in Grant County. And in the future, we really hope to partner more with additional health systems and provide that administrative support for providing CDSME workshops in their communities and growing the capacity of the programs. We also see an opportunity with Colville Confederated Tribes in the Wisdom Warriors program, which is a culturally appropriate adapted version of CDSME approved by Kate Lorig and SMRC. We also saw that a lot of our folks that come to our workshops from managed care organization clients, and we see an opportunity there to partner there. And then we also think that utilizing our partners' knowledge of their communities to create better and more culturally appropriate outreach for future workshops. And then, so opportunities kind of summed up. We believe in the success that our participants have had in this program, and we think that partnerships can really grow the capacity and the frequency and the regularity of these workshops through partnerships of whatever community-based organizations and health systems. We really see the opportunity to grow and equip lay leader and community health worker workforces with self-management tools. And we also see an opportunity to partner with some of you with the Whole Person Care Collaborative, you know, the Medicaid Transformation Project. Obviously, you guys are aware that chronic condition management is a goal. And we really see that through the past of our program that we've showed changes in chronic care management among our participants with a 42% increase in behavior change, 45% increase in participant confidence, and a 71% increase in quality of life. And we hope that through partnerships, we can really start moving towards that effective admin system, increasing lay leader capacity, and increasing available and regularity of workshops, like I said. And then lastly, our virtual workshops. I did want to give just a little shout out to our one starting in January. We are providing a 0 session kind of Zoom info session on January 7th, and then starting our classes on the 14th. This is again free to anyone who would like to participate. And then we just added some resources that you can look at if you'd like that show the successes of the evidential support of the CDSME programs, as well as some videos and websites with some more information. And then we can open up to some questions if anybody has any. If there's not, you can definitely reach out to me through email if you'd like. And we just really thank you guys for letting us present today.
Thank you.
Thank you.
Thank you. Sorry, I had to find my mute button. I never know if I mute myself on my phone or I mute myself on the computer. You had my control, so I did it on my phone this time. And then I couldn't turn my video back on after shutting it off for a minute. So thanks, appreciate that presentation, really good. I have a couple questions, but before I ask, I just want to ask one more time, does anyone else have any questions regarding the chronic disease self-management program? I'm curious, on the data you presented at the beginning, you said that family health centers, mostly community health and Action Health Partners all have the license. The data you presented, was it only from Action Health Partners or is that the aggregate data from all 3 programs?
So that's just Action Health Partners data. When family health centers and I worked underneath our license in a few years ago, that data is in there, but that would still be underneath Action Health Partners license. But those were a lot of our Okanagan workshops in the earlier years.
Great, thank you. The other thing I wanted to just point out, one of the successes I think as the WPCC comes back from the behavioral health integration learning activity when we started with this, one of our first learning activities. And right after that, I believe, Jamie, please correct me if I'm wrong, but right after that, Jamie with Catholic Charities, was setting up her risk assessment, and she found a gap in knowledge in her case manager. So think of your behavioral health case managers and the knowledge they have around chronic disease, especially chronic disease self-management. And that's how that partnership began with Action Health Partners and the trainings. Jamie, are you still on the line? Would you be willing to speak to it from your point of view? Because I think it's a really good example of behavioral health integration, or how behavioral health integrated physical health into it. And educating the case managers. The case managers are then able to really help their clients on their caseload with their own self-management. Not that they're giving advice because they don't necessarily have the experience in that, but they're able to convey some of the messaging that they've learned. But they are also more confidently able to convey the message of following up with your primary care provider for their physical health and understanding of why and how their physical health interacts with their behavioral health. So I've given Jamie a few minutes that if she's still there, that she could unmute herself. So I will wait and see.
Wendy, I don't see her on anymore.
Okay. Caitlin, can you speak, or is anyone else on the line from Catholic Charities that could speak to that?
Well, I can speak to it a little bit. I know that, like you said, obviously they're not going to go outside their realm of knowledge of like what they can talk to their clients about. But I think the tools that you learn, like action planning and problem solving and that kind of stuff, really was from what I heard was really beneficial, because they were able to provide tangible tools to help clients on health goals and other goals that they may have. Yeah.
Very cool. Well, thank you. Anyone have any questions? I put the link to the flyer one more time in the chat box in case you're interested. There is Caitlin's email address. If you have any additional questions, feel free to give Caitlin an email. Shoot her an email and she'll be happy to help you.
Wendy, can I say one last thing? Sorry.
Sure.
But I just wanted to explain the flyer. It's just a one-page summary of the information that we shared today, maybe a little bit more than we shared. So again, peruse it if and when you have time. And then Caitlin's contact information is at the bottom too, if you have any additional questions about it. So thank you for pulling it up, Wendy. Thank you.
Yep, absolutely. Caitlin, maybe you can send me the flyer to your virtual training or information session and we can send that out.
That would be great. Thank you.
You're welcome. All right, so I'm looking at 12:25. There's about 20 minutes. I was going to do small group, but I think I'm going to skip small group this time. I want to hear from you guys. I want to do a 2021 look back. I thought I would end this on this high note of looking back of what has challenged or changed you. You cannot say COVID, because we all know that's challenged us tremendously, and we all know that that's changed us tremendously. Now, what you could say could be related to COVID, but I'm just interested to hear how, it's more of it's like, how have you grown through all of this? Because I know that it has changed a lot, and I could say changed or challenged us a lot. And I could say, I'll shoot it off while you were thinking about yours and what you would like to say. One thing that's challenged me, I'll say, is I'm pretty much an extroverted person, and I love to be around people much more than I like to be around myself, by myself, I should say. And so what's really challenged me is working from home in my little four-wall study here and not being around you guys even monthly for those who are able to join us in person or my coworkers. And so what's challenged me is how do I reach out with relationships in a different capacity so that I maintain them and I have that interactions. And just a quick story. And as an example, for Thanksgiving, my son did not come home and he's off in medical school, and we played games online. I'm not an online gamer at all. I'm in my 40s and just never reached that level. But playing for 2+ hours online with my son and his girlfriend, my husband and my daughter, was pretty amazing. And it was a very cool way to reach out in a different way than I've ever done before, to have that interaction with and have family time on Thanksgiving. So that I'm very thankful for. So I'm going to open it up. I don't want to call on people. I just want to hear from you guys. What have you been challenged, or what has changed you? What have you changed over the last year? Who would like to go second since I went first? Don't all speak up at once. There's a brave soul out there somewhere.
I'll speak. This is Tawn Thompson from Family Health Center. And it's hard to put a positive spin on this, especially for those of us with children that are supposed to be in school. So it's been extraordinarily difficult. But I am very impressed with a lot of these institutions that were blowing up because we have to make all these new ways. I'm hoping we keep the good ones. Like telehealth is a great option for those of us in rural areas and getting some of those hard to reach populations. If we can start using it really thoughtfully in the future when we don't have to for the pandemic, that's going to be great. And for schools, some children are doing better remotely and some teachers are a better fit for it. Like maybe we can take some of the good parts of this and go on for the future.
Thank you, Tawn. Deb?
So I'm going to say the thing that COVID gave me the opportunity to do is to dive into my own self-care and well-being this year. I dove into 8-week John Kabat-Zinn mindful-based stress reduction that I also piggybacked with Teresa Pasacani's self-leadership cohort for 6 weeks. And it was pretty incredible because for all of us, this is really emotional times, right? I recognize that we're no more unique than healthcare providers, but we also have dealt with COVID and our clients pretty significantly. And to be able to emotionally regulate myself in a healthy manner has helped me, I hope, be a better leader, though I guess there's 2 people that can say yes or no on this call. Thanks.
Thanks, Deb. And it doesn't have to be personal. It could be something that's different that's changed at work that you found that you would have never done, or maybe you've considered but never had the opportunity to do, but now you're doing and it's successful.
Hi, this is Kristen at CHPW. I kind of to piggyback off of what you just said, Deb, but just culturally here at work and then personally as well, focusing on the mental health and well-being of my team, my colleagues. We've really over the last 9 months have done such an amazing job saying, stop, ask yourself how you're doing, ask your teammates how they're doing, and really try to make sure that you're keeping up with those connections, because what I think everybody has realized who is working remotely, I had no idea the things we accomplished just by being able to sit up and pop our heads out of our cubes. And so the number of emails has greatly increased, but just paying attention to that and making sure that we are consistently checking in with one another and bringing mental health to the forefront has been a nice, wonderful change, I think, across, like for me personally, and then also across our organization.
Thanks, Kristen. Tessa?
I thought you weren't calling on people.
I know, but I saw you unmute it, so I thought I would just.
I think, I saw that Christina had put it in the chat as well, and I agree. I think, providing telehealth to our patients in this way is something that we wanted to do long before COVID happened. And I think COVID really jumpstart that for the entire nation and provided care to our behavioral health patients that I think that the majority of them wanted. So I'm excited for what this option brings for the future. I think the struggle as a leader that I've had through this whole thing, that I probably share with a lot of my colleagues, is how do we keep the team engaged and connected virtually? And I think that's where I've had to really dig in to my creativity, and which I'm way better in person, I've realized. And so just really relying on my colleagues to find out what they're doing. And so that's the biggest piece, like all of you guys. I mean, I worry about my team and their mental health and all that we're taking on during this time where everyone is struggling with anxiety and we're kind of all in it together. So.
Thank you. Who else? I know there's
Mary
more out
Jones,
there.
Mary Jones, just the fact, the learnings that what we thought was impossible, like getting telehealth up and running in such short a time, or even the majority of people not working in a physical building. Just the fact that we all survived doing these major changes that I think we would have thought, oh, we couldn't do that, and yet we're forced to. So it has been interesting to see people willing to think outside the box, literally, this year more.
That's true. And it's amazing. I think the people didn't want workers working from home because they didn't think they would be productive, yet lo and behold, the work still got done. Who else? Is it that awkward silence? Awkward Zoom silence, not even just in the room, but Zoom. It's like, don't look at that person. She might call on me. Now you can just turn your video off and I don't have to stare you down, right? I do appreciate that mental health has been normalized or is being normalized, and not as, that kind of pushed it forward. And those in the behavioral health world could probably speak to it much greater extent than I have, but where it was once a taboo topic that you didn't want to have a mental health issue, recognizing, or you didn't want to admit you had a mental health issue, you're recognizing that you're not alone. Many people do. Okay, I'm going to give one more call out, something that's challenged or changed you. Be brave and mute yourself.
This is Sahara with the ACH. I'll go. I would say one thing that's changed is it really forced me and our team to innovate how we deliver meetings. Much of our work is convening partners, and particularly with the Coalitions for Health Improvement, I think going to virtual has changed the reach and the impact in some ways. It's also changed some of the things we can and can't do in the room or virtually. And then personally, I've been fortunate to get to take a walk outside every single day since all of this happened. And that was certainly something that I placed on the back burner in years prior. So I'm really grateful for that opportunity.
Thank you, Sahara.
So Wendy, this is Linda. What I would say is at the beginning, of course, it was so challenging because North Central ACH got asked to stop our projects, put them on pause, and be part of the incident command team and work really hard to help the health district. We're still going through changes at the health district. I feel so grateful to have Nate here temporarily. He's here with the Department of Health. I would say the positive thing for me is that I have seen in our staff how much resiliency there is. I mean, we talk about it, but we have lived it. I mean, we're still here. And I think the most positive thing for me, and Sahara helped put together the December executive newsletter, is just the gratitude. There's so many. I am constantly thinking more about things that I am grateful for. So that's positive.
Thank you, Linda. Anyone else? Okay. I think we'll call that a day then. Thank you everyone for attending. Thank you for those who shared. I'm looking forward to 2021. I really am. I think there's going to be some new and exciting things that are come out of it. I'm looking forward to what the future holds. the great work that you guys are doing. So I remember there's no meeting in January, so our next meeting will be February 1st, and I'll just show this real quick so that you have that visual and you will remember. No meeting in January, next meeting February 1st, 2021. If you guys need anything, let me know. Population Health Plan is tomorrow for those teams that are joining us. And without further ado, I'll let you guys go. Have a very Merry Christmas. Enjoy your holidays, enjoy your family, and we'll be talking soon. Thanks, everyone. Bye-bye.